Good afternoon, everyone. It's great to see a full room for a very exciting session, and one that's really going to provide foundations for a very important project in the transition, or the career transition framework that's going to be developed. Before we get started, I just wanted to let you know that as a board member of APNA, we've put in a strong recommendation that we get the Hydrolite stand here next year. We seem to need it, particularly after the gala dinner and in the morning. I'm not sure if there's any other requests. Maybe we could forget the children's Panadol and maybe just go straight to the adult Panadol next year as well. If we put them next to the Hydrolite stand, maybe on the way out of the gala dinner, that could work very well for all of us. So welcome, and thank you in advance for your participation today. There's a few things we're going to get you to do because we are at the beginning of a journey and only a couple months into what is a 3-year project. It's an interesting one here because it's not often that the needs of healthcare, the policy environment, the direction of a peak professional organisation, and the needs of the individuals in a particular profession come together, and in this case they have. And that's resulted in a number of projects being commissioned by the federal government and through the Department of Health. We're going to get into some of the detail about transition to practice in as much as sharing the interesting and varied career pathways that people have in Australia today in primary healthcare nursing. We're also, and you'll see the sheets of paper on your table, we're also going to get you to share your pathway in your career to date as well. And that's going to help us gain some very strong insights that we're going to be able to feed into the development of this project and ultimately in the recommendations that go to government and also in the framework once it's developed. We've got a number of people who are going to help us get into that discussion today, and I'll introduce them about 20 to 25 minutes in. People with very varied careers, but all who call themselves primary healthcare nurses as well. Before we start, I'd like to pay my respects to the elders, past and present, of the Kulin Nation, on whose land on which we stand. I'm a big believer in the recognition of Aboriginal and Torres Strait Islanders, so I like to go beyond that and actually tell everyone a fact, an interesting fact about the nation's land on which we stand. And so the Kulin Nation, actually the oldest burial site for a member of the Kulin Nation that's been identified in Victoria is 7,300 years old. Puts into perspective the sense of pyramids, which we say are 5,000 years old, but that's the oldest burial site located in Victoria of members of the Kulin Nation, and shows just how far it goes back. Just south of that site is actually a quarry which was used as far back as 45,000 years ago, where members of the Kulin Nation would travel by foot to in order to create axe heads. So it just shows that sense of history that we don't always appreciate is sitting there behind these recognitions of our traditional owners. So we're going to get into the nuts and bolts of this today, and we're going to start by giving you a bit of a précis of where this has come from. So I'm going to call up Karen Booth, our President of APNA, to give you a sense of the bigger picture before we get into the nuts and bolts of this project with two of the people who are heading up the project on behalf of APNA. Thanks, Karen.
So for me, I think to share a bit of my story, I worked many years in emergency departments, in ICUs, and then was teaching at Uni of Western Sydney before I stopped to have children. And when I came back to work, I started working just a couple of days a week in general practice. And in fact, what I started doing, I was asked by some GPs I know if I could help them migrate their information from their paper files into a computerised records when the immunisation register first started. So I started out just doing that for a couple of hours a week. And then when I was in the practice, they said, "Oh, can you do an ECG?" I went, "Of course." And, "Can you do a dressing?" "Oh, yeah, sure." And then from that, I ended up a couple of days a week full-time and then sort of have cut down again. But I think in that interesting time, amazing things have happened. So apart from me learning a bit about a new area that I hadn't worked in before, all of these changes came. We had immunisation register, health assessments started, managed care planning started. So that was all, around that sort of 98 period. And so I think at that time they realised they actually needed to have a nurse all the time. One of the other interesting things was that there wasn't actually much CPD-wise or education-wise at the time for me to know what sort of which direction to take. So some of that came when general practice networks were funded, and they were funded mostly. The education that was provided was to drive particular projects. So with that, and the same with the Medicare locals, the CPD related to particular projects. So education, there was sort of instant available education related to incentives, but not actually related to my learning needs. And so most nurses then developed, or a lot of nurses developed, along the lines of the education and the project needs without actual thought to what they actually professionally needed. And the other interesting thing was I had been a clinical nurse specialist in an emergency department. I'd been 2IC in an emergency department, relief lead in an emergency department. And when I came into general practice, they just said, "Oh, how much do you want to be paid?" And I was very excited. I went, "Oh, $25 an hour." And that was a long time ago, mind you. But then for 5 years I didn't get a pay rise. And there was no actual, once you in general practice, there's no actual, milestones for you to move. There's no clinical nurse specialist. There was no charge relief. There was no formalised, level of consultant. So it didn't matter where you were from, and I've met lots of nurses who've done amazing things. You end up in this area and you're all just grouped as the same. And I think it's led to certainly a lot of frustrations in the workforce. And so previous work that we did was recognised that we actually needed to look at who we are, where we are in our professional development, so that we can not only sell what we do, but how do we gain personal satisfaction. And we realised some time ago as well, we're being approached from nurses in other areas of primary health care who were wanting professional representation. So a number of years ago, we opened up the umbrella from just general practice to other nurses working in primary health care. And we realised that the same frustrations that we've had with our working out who and where we are professionally, other nurses in other areas of primary health care are the same. And so the work that's coming, the work that we've been funded to do over the next couple of years, is to actually be able to set the scene not only for the people we work for, not only for the people that we work with. Let's other nurses and bureaucrats and health professionals outside our own work areas know where we are. But I think professional satisfaction and understanding who you are, what you do and where you sit keeps you in your job. And now I'm going to hand over to Bronwyn Morris-Donovan, who's going to talk to you about the work that APNA's doing.
It's beautiful to see so many people here this afternoon, and I recognise quite a few faces from the PHN pre-conference workshop, so it's lovely to have you along here as well. I'm Bronwyn, I'm the Director of the Nursing and Primary Healthcare Program, and I'm going to walk you through about 10 minutes of the NIPHC program before we move into the crux of this work today, which is our expert panel around the Education and Career Framework. So by now we're all of the same page that we know that the NIPHC program is a 3-year Commonwealth-funded piece of work, and it's distinguished itself from the NIGP program in that NIGP program where we've moved from the singular focus of general practice to the whole focus of primary health care. And that's what really sets this piece of work out, is the change in the scope of the work that we're now doing. Fabulous. Okay. These next couple of pieces of slides are actually really important to keep in the back of your mind while we move through the rest of the afternoon. And that's because they set the scene for what the NIPHC program's really designed to do. And these three intended outcomes speak to those higher level policy objectives that Karen Cook was talking about this morning. And that is that the work of NIPHC either relates to recruitment or retention. So recruitment of nurses, new graduate nurses, or nurses from the tertiary sector into the primary healthcare sector, and then retention of nurses who are already working in the primary healthcare sector. And almost every element of the NIPHC program touches upon either recruitment or retention. We're also looking at models of innovative or best practice nursing care that can be replicated. And it's that second part of the sentence, the replication, that's actually the most important component. And we'll get onto that a little bit later. And then the final piece is we're looking at increasing the knowledge and the skill set of the workforce. So if we think about that growing demand of chronic and complex disease, coupled with an ageing population, we need to have a workforce that has the skills and the capability to respond to those demands. So, this slide for me is everything really in the whole NIPHC. And that's because if we want to achieve the desire to respond to that growing demand of chronic and complex disease and an ageing population, then we have to achieve what's in the top line, and that is increasing workforce capacity and capability. And the way that we do that is at the recruitment and retention end of the spectrum. So the work of NIPHC is entirely based around recruitment and retention as a vehicle for achieving increased workforce capacity and capability as a way of achieving those overarching policy goals of how we respond to that growing demand. And I think that's a really important slide to keep in the back of your mind when we begin to talk about the education and career framework, which has a basis in both recruitment and retention. So there's 4 projects in the NIPHC program. There's the Transition to Practice pilot program, which you've heard a little bit about this morning. There's the Enhanced Nurse Clinics, there's the Education and Career Framework, and the Chronic Disease Management and Healthy Ageing. I'm not going to talk too much today about the chronic disease management and healthy ageing, but they're really workshops, they're 2-day workshops designed to provide increased levels of skill and knowledge and capability and understanding of the factors that contribute to chronic disease management and healthy ageing. I'm going to talk now for about 5 to 10 minutes about the Transition to Practice program and then about the Enhanced Nurse Clinics. So, this is our aim for our Transition to Practice pilot program. It's big and there's lots of things in it. And if you unpack it, what it really means is that we're designing a transition program that is flexible, yet structured. It's a program that achieves the goal of increasing workforce or the skills and the knowledge of the nurses that participate in that program. And if you unpack that even further, one of the complexities with that, if you think about accessible, for example, it needs to be a program that's cost-effective from a funding perspective, cost-effective from a doing perspective, if the nurse was ever to have to pay for something like this. And it also needs to be at a level that is accessible. So that means that the barrier to entry is not too high. And that's why we talk about this as a program. It's not a postgraduate piece of work. It's not a certificate level course, it's a program. So there's 2 tranches with Transition to Practice. The first tranche has just started and we have some of our transitioning nurses with us today, so welcome, it's lovely to have you here. We have 25 nurses in tranche 1, and we had 117 applications, which was astounding for us. So we opened our application process just after Christmas, at a time of year which was reasonably quiet, and we still got 117 applications. So I suspect we've just touched on the surface, and in tranche 2 I would expect to see almost double that number of applications, and they were fabulous applications. Now, the reason I put this next slide in is I think it's really important. If you look in the literature, there's a whole lot of information about transition programs or grad year programs in the hospital sector. And it's really reasonably straightforward. Everyone's employed by the same organisation and they're physically in the same space. So it makes the work of preceptoring far more straightforward. And one of the unexpected surprises or consequences that we saw in our expression of interest process was we had large numbers of nurses working in practices with 1 or 2 GPs as a single nurse wanting to participate in the program. And if you step back from that and think, well, that means that we don't automatically have a preceptor who's on site, employed by the same organisation, who can offer that preceptoring role. So we had 2 choices. We could exclude those nurses from the program or not. And we decided to include them for the very reason that's actually what's going on. And we need to have a look at whether the model of having a preceptor externally located from the practice is in fact feasible, is it viable, and does it produce the same types of results. So we've ended up setting ourselves up with a transition program where we're trialling 2 models of transition to practice. And then what we learn from this transition tranche, we'll then apply in the second tranche to have a look at what are actually the factors, what's most important for a transitioning nurse. And that leads me to this slide. If you break it down and you have a look at what are the elements that are important for a transitioning nurse, we know from the literature, but we don't know much about what's important in primary healthcare specifically. So we have a self-assessment framework that the nurse completes with their preceptor, and that guides their educational learning. We have preceptorship, we have mentorship, and we have the role of APNA, and then we have the education activities or the education modules. And what we're doing with our evaluation is we'll be ascribing a value to each of these activities or items. So then we can begin to describe what are the most important elements of a transition program. If we had to choose between mentorship and preceptorship, which one would we choose? And I don't think we know the answer to that yet. And ideally we would say, well, we'll have both. But if the department said, well, you can't have both, you can only choose one, we need to have a pretty sound rationale for why we would choose one over the other. Okay. I'm going to move on and talk to you about the enhanced nurse clinics, which looks like the demonstration projects, except the scope has been significantly broadened out. So really the intention of this piece of work is to model nurse-led clinics in the primary healthcare setting. And as we said at the very beginning, what's really important about this is beginning to understand what are the characteristics of nurse clinics that can be replicated. So we're piloting 11 nurse clinics, and if we pilot the clinics and we just have a look at each clinic individually and we run 11 good clinics, that's great. But really it's actually about understanding across those 11 what makes them work, what makes them sustain, how do we fund them, so we can begin to get a better sense of a model. And we're not assuming it's a one-size-fits-all. It's not, because of the diversity of primary healthcare. But we need to get a better sense of what models, plural, might actually look like. So, again, with our application process for this piece of work, we had 78 applications, which told us a lot. Firstly, it tells us there's a whole lot of work being done already around nurse clinics in Australia. And for a lot of the applications, these are clinics that have been running for a period of time in quite diverse settings, from general practice, aged care, correctional health, community health, nurse practitioner-led models, RN-led models, you name it, it was in the 78. And what's most interesting about that is we're now thinking about what we're going to do with the 70 that were not successful in this round. And of the 11 that we've selected, we've chosen them really carefully because they offer us 11 quite different learnings. So rather than choosing 11 that were the same, we've gone for things that offer us a better understanding of what is it like in a regional area compared to a remote area. What is it like in a general practice setting compared to a correctional health facility? And I suspect if we did this again, we'd probably be far more focused. We probably wouldn't open it up quite so broadly and we'd narrow it down. But it was just incredible to see the depth of applications that we received. Okay, I'm going to touch on this slide, and I think it's important to give you a sense of the methodology that we're applying for the Enhanced Nurse Clinics program. So we're working with the Improvement Foundation to take an equality improvement approach, and they've reviewed all of our content and our methodology to ensure that we're on the right track with this. We've chosen to adopt the collaborative methodology, and if you look at the wave down the bottom, what we really mean by that is at the beginning of the program, the nurses participating in the Enhanced Nurse Clinic program at the end of May will meet for a face-to-face 2-day workshop. They'll then go back to their clinics across the different locations and settings across the country, and they'll participate in structured learnings, which looks like webinars or teleconferences, and in between those learnings, they'll engage in rapid plan, do, study, act cycles. And we're really interested to have a look if the quality improvement approach is actually what makes the difference between nurses and practices having a good idea and actually being able to get it off the ground. This last slide, I think, is probably the most important slide because it gives you a sense of why we're actually doing this. What are we really wanting to find out? And what we want to know is what are the characteristics of a nurse clinic that are really important if you're going to set up a nurse clinic? So how do you establish one? How do you embed it? How do you sustain it? And how do you fund it? So we need to get a better idea of the existing funding mechanisms that are currently being used, but also to begin to ascribe a value to how cost effective they are. And that's probably the missing gap, and that's the piece of work that takes up most of our time, because it's probably the most important outcome that we would like to achieve out of the nurse clinics. So this afternoon, immediately after this session at afternoon tea, the whole NIPHC team who are here today will be at the APNA stand. You can come and ask us anything about any element of the program. I'll be sitting on the panel this afternoon, and you can also ask questions then, but I'm conscious we don't have a huge amount of time. I'm going to hand over now to Emily Wheeler, who is the Project Manager for the Education and Career Framework. We'll touch on that piece of work, and then we'll move into our panel discussion. Thanks very much.
Hi everybody, I'm Emily, as Bron mentioned. Really excited to be here, and I'm really excited to see so many friendly and inspiring nurses in the room, and we really hope to involve you in this project, so thank you for being here. So a significant amount of expertise and knowledge is within this APNA network, just looking around the room here, and we really hope to tap into that with this project. The project, the Education and Career Project, I've only been in the job for 3 months, so we're really at the beginning of this phase, but it's been a really interesting process so far. So as Bron mentioned, the key aim of this is to improve the recruitment and retention for primary healthcare nurses. And we're doing that through the development of a framework and toolkit to describe the career pathways and their education underpinnings for primary healthcare. We hope to enhance the education opportunities for career progression, and the project itself is 2.5 years, so we're at the very beginning of that, and we hope the outcome will be really positive for this sector and this profession. So where are we up to in this very short 3 months? We've completed an environmental scan. Our knowledge of primary healthcare nursing and the different settings that we can touch with this project is really comprehensive. Literature reviews been completed on similar models within nursing internationally and within other similar professions, so to help to form the foundation of this project. We have a draft framework structure already in development, which we've been testing out with a few key stakeholders, and the response so far has been very positive. And really what we're here today to say is this is the kind of formal launch of the consultation process. We are keen to work obviously with APNA members, but then through all of you and your networks and your friends and colleagues who are nursing and also non-nursing, because we really need, for this framework to be successful, ultimately our non-nursing colleagues also need to be part of this journey, and we need to convince them, get them to come along with us on this pathway and take it up to make all of our lives easier. So really what I'm here to do today is to ask you to join and be part of this discussion. and to share that opportunity with your nursing friends and colleagues and the wider health workforce. We are holding a series of key stakeholder workshops. Some of you may have already heard about them. We've commenced promotion just recently. There should be flyers on most of the tables. Otherwise, as Bron mentioned, in the afternoon tea break, drop by the APNA booth and we can share that with you. The first two are in Sydney and Melbourne. We'll see then what the response is. We're really keen to hold them in, as far and wide as there is interest. So if you are unable to attend those meetings, obviously it's location specific and we appreciate that. So please let us know that you're interested and we'll try and make sure that you're part of the consultation. And we really just welcome all of your expertise and knowledge around this, and thank you.
So thank you, Emily, and thank you, Bron. It's one of the great things as a board member is you get to see the theory behind a lot of things and get to pass a few judgments based on your best experience at the time, but then you come to the conference and you start talking to the people that the staff at APNA have been talking to, and I thought I'd be quite happy to share this piece of feedback, which was, having spoken to a few people who've been involved so far, I asked one of them, well, what's your experience been so far and how's the engagement of the team been to date? And they said, oh my God, they walk on water. And I thought, you know what, it's not often as a board member you get bailed up to have people tell you just how great something is going when we're at the real foundation stage of such an important piece of work. And the great thing there is this is a collaborative process. This is something where we have a very clear structure for how this will be achieved, but we're going to learn a lot of things along the way. And that's one of the brilliant pieces about how this process has been developed. So I encourage you to give your feedback and talk to the team. This is a 3-year project and we're at the very beginning of it, and we need that rich source of insights at the very beginning to make the outcome as robust as possible. So now we're going to get into a bit of the nuts and bolts about this and where the rubber hits the road, because we've got a fantastic selection of people who have been engaging with the project to date. And I'm going to get them up here in a minute. The interesting thing also with talking to nurses broadly about their career pathway and is that you tend to get two groups in my experience, and that is those who go, well, I've kind of muddled my way through my career and I've done a whole heap of things, but I'm probably a bit of an outlier, so you wouldn't want to hear my story because I'd probably skew your data in some way. And then you get the others who go, well, I've kind of muddled my way through the career, but everyone kind of does that, right? So, I'm kind of boring. You don't really need someone like me in there. And the reality is, the more we start looking at the pathways people have taken through the career, the more intriguing it becomes. And I think the 5 people we're going to have on our panel now really demonstrate that too. So I'm going to invite them up and give you a quick bio for all of them. So the first member of our panel is Ben Gorry. So Ben, come on up. So Ben currently is employed by Victoria Police as a custodial nurse, providing all aspects of healthcare. So his tasks include, or his remit includes mental health, physical health, drug and alcohol problems to detainees in police facilities across the state. So Ben's also on the board of directors of CATSANAM, the peak professional body for Aboriginal and Torres Strait Islander nurses and midwives. So welcome, Ben. So the next person is known very well by this audience, and that's Jo Perks. Jo is a women's health nurse practitioner and registered midwife working in Sydney. She's been contributing her extensive experience in a variety of representative community roles for APNA and generally making primary healthcare nursing in Australia a much better place. Welcome, Jo. We've also got Bernadette Suter with us. So Bernadette's role is practice leader nurses, clinical governance at CoHealth. She works with CoHealth nurses on a range of activities, including professional development, both individual and agency. She also works with nurses in a wide variety of public health initiatives, including the development of viral hepatitis strategies. So welcome, Bernadette. I'd also like to invite up Mel Cromitty, who, as well as being a brilliant nurse, has just joined the APNA board. So Mel's a team leader of practice support and development team at the Hunter New England Central Coast PHN. Mel's team of 10 supports GPs, practice nurses and all general practice staff in a range of activities. Mel also undertakes the role of clinical lead for the broader team encompassing a large geographical patch and 22 staff in total. So welcome, Mel. And our final panel member is Kathy Orse. Kathy is a practice nurse working at a general practice clinic with 5 GPs in Kew here in Melbourne. She joined the practice in September last year and works 5 days a fortnight. She was one of the 25 successful applicants who recently joined the Transition to Practice pilot program, which is part of this overall project. So welcome, Kathy. Can you bring up my presentation? Thanks. So I brought them up and I've just told you I've got a presentation, but it's not what you think. So this is where we start off with something a bit practical, which is some of the stories from this diverse panel that we've got. But we've also got a sheet on the table in front of you, which we're going to ask you to fill out in about 20 minutes or so. But hopefully their careers being mapped out on those sheets gives you a good sense of what we're going to ask you to do in about 20, 30 minutes or so. So what we're going to do is go through the careers of some of our nurses here using this sheet. So the first one I've got is Ben. So Ben, this is the first time you've seen this in something that's the size of a small bedroom. Surprise.
It's not really that exciting, is it? As you can see, I'm fairly young.
So this sheet demonstrates Ben's young and tender years, so you can see that he's already taken on a few roles. But Ben, walk us through your career today.
Yeah, so like I said, it's not very exciting, is it? It's only a couple of years in there. It's interesting because I started off sort of with this grand idea of working in the helicopters as a microparamedic, and that was where I was wanting to go for my whole life. Did nursing first and just fell into it and loved it, so I've stayed there ever since and haven't transitioned across. But I always thought I'd work in the critical care environment, loved that side of stuff there, and that's what I started doing in the early years of my life. Got a little bit over it and kind of thought, what else is there? I'd like a new challenge now. So then I sort of transitioned over to mental health and worked in there, but it was still in acute mental health services there. And then sort of just, as Ken said before, sort of muddled my way through and then fell into this primary healthcare role with the Victoria Police that I'm doing at the moment.
So just picking up on that point, so put your hand up if you think you've muddled your way through your career. Excellent. So reason we need the project, right? And then how many people ever describe themselves as falling into their current role? Yeah, about as many hands. That's great. Okay, fantastic.
I think it's a good point because I mean, a lot of sort of doctors and medical students, friends of mine, have got this career planned out from the moment they finish Year 12. You've got the whole life planned out, what course they want to do, what trainee they want to do, all that kind of thing there. Whereas myself, a couple of other nursing friends, we just kind of waft from one place to the other. Whatever the new challenge is, we'll take up that there, or here's an opportunity, we'll go across there. And probably, I'm sure, as we go on there, you might see this sort of transition across left to right. And maybe that will happen later on in my life as well.
So how many of you've got the numbers there, and I should explain to people who haven't already looked at the sheet. On this, we get people to put numbers in the right-hand column of the various bits to see what level of, what level that they're working to throughout there. Because one thing we want to capture is, well, do people have to sort of step back in a way at the point that they transition to another area? So, Ben, give us an idea of the twos and ones you've got up there.
Yeah, well, obviously one, novice practitioner or student at the time there, so I didn't feel I was qualified to put anything higher. I may have thought I was an advanced person, but definitely, really, I was just still learning. At this stage, I think I have a bit of an advanced level of knowledge. I wouldn't say expert. I don't think I'm ready to say expert because there's still things that I'm continually learning every single day, and obviously within the new sort of environment as well, that, yeah, there is going to be challenges there. I think I'll be that sort of advanced mid, just switched over from 1 to 2 there. As you can see, there was a little bit of a, I think I initially put 1 there, then I changed it to a 2, then I think I changed it back to a 1 again. I was a little bit confused with one there. I was like, which way do I go? But yeah, I think I was pretty happy that I sat with 2 there.
Excellent. And what was the biggest help when you transitioned from one sector to another?
Not too sure, really. It was I think it was pretty much mentors and that kind of thing, and role models. There was a lot of other experienced practitioners within my workspace, but other friends and other people that I know through Katsanam as well. So just having talked to them, finding out how they've done the same thing, either transition from one workplace or one completely different area of nursing to another, and seeing how they helped it, and they helped me with that there. And yeah, so definitely it's that role modelling. Actually, I want to be like you. I'm going to go for that, and also that mentoring is actually asking that and seeking that feedback and helping support that process.
Fantastic. Thanks, Ben. We will come back to a couple of those themes. Now, pressing the zapper button. Thanks, Ben. So the next one, Mel. I thought we'd jump around the panel a bit. So Mel, yes, it's the size of probably a double bedroom in inner city Melbourne, I imagine. This screen, you haven't seen it like this before, but it is good to see that you've got a fax in your practice though. So walk us through your career a bit.
And actually, having a look at that up there, you can identify our ages. I didn't think about that. It's a bit evil.
And we started with Ben, so.
I started very differently. I think I danced around it very differently. I started out as an enrolled nurse in aged care, and feel that I worked there to the top of my scope, where then it was time to move on and put myself through university, which was a fairly big challenge. I was quite young and a child of the youngest of 6, so had other challenges that my mum and dad were ready to sort of get rid of me, but I wasn't quite ready to leave the nest. So put myself through uni then, and did my registered nursing, and I ended up in the critical care space because I'm a little bit of an adrenaline junkie. So I spent the majority of my career dancing through the ED, and then when I got a little bit tired of that, I'd go to intensive care, much like actually Karen. So when I would have enough, I'd go to intensive care for a bit of a break and then come back to the ED. And I was really passionate about emergency nursing and loved it. So I studied there as well. I think I had great mentors and enablers to my career pathway when I was in the tertiary system. So I was always encouraged by great leadership to push to the top of the study ladder. So in emergency, I was encouraged by my manager to do postgraduate studies in critical care. So I did that. And then I had children and found that night duty and kids and family life and all of those things wasn't quite working for me so well. So then I fell into practice nursing. And when I got there, that was great. Probably the biggest change for me was that these people come back. In the ED it was see them, sort them, send them. In the general practice, it was see them, sort them, but hang on, they come back. It was like, and they remember your name, so it had to be nice. And again, this is where for me the pathway got a little bit muddy. I didn't feel that there was a clear education pathway for me to follow, and I found it really challenging that I also didn't know where to go to get that information. And if I'd be critical of what I did, I probably wasted a little bit of money, because I started different things and then thought, well, this is not really what I want to do, and it wasn't what I was hoping to achieve from it. I did do the graduate certificate in general practice nursing, which was great, but when I look back, it didn't actually give me the skill to do the job to the best of my ability.
So just on that, how many of those changes do you think were your choice? As in, you consciously decided, I'm going there, and you ended up at the place you wanted to be? I don't think... So in the tertiary system, when I was an ED nurse, I felt that was my choice because it was modelled before me, so I could copy off others, for want of a better term. But in general practice, I didn't feel I got that, and then I ended up with what was then the GP Access, or the Division of General Practice, because I felt that I had a lot to offer in general practice, but I didn't know where to go to extend that knowledge. Right.
So, yeah.
Great one. And the rest of it, what do you think was the most rewarding shift? And not just on a professional level, but on a personal level as well?
It's actually been into the primary care space, because I think we have... we've really got the power to change and I guess influence health outcomes. And a lot of the time, as the ED clinician, you're fixing a problem that perhaps, could have been fixed, or probably would have been fixed a lot earlier if there was better intervention pathways. Yes, I think primary care definitely for me.
Fantastic. That's what we love to hear in this audience. Thank you, Mel. So Bernadette, you've got a varied career much like Mel, and how would you summarise that for us, or walk us through it?
So I trained in a hospital and spent quite a few years in intensive care and absolutely loved it. And I think it's something about working at that real edge that's was very rewarding and dynamic. However, also working in the general wards, I always felt an unease at that time about my relationship with clients, patients. I always felt that it was sort of my way or the highway a bit. It was sort of what we had to get done in a day. And then I experienced some community health nursing, and I just felt a complete change. So in a way it was quite a political position that I took in regard to moving into community health. So community health being part of primary health, and it provided me with a framework where could still use really clear, solid nursing skills, clinical skills, particularly clinical assessment skills, but sort of working with people from I suppose a more empowerment level, and working around sort of the broader background issues around health promotion as well. And then but by working at that grassroots level, really starting to understand, I suppose, new changes in health. So a big influence on me was HIV, and really understanding where Australia was at that time and Australia's response, and it was really quite courageous, really looking across the world, particularly looking at needle and syringe programs. So I was involved in starting one of the first needle and syringe programs in community health in Victoria. There had been some trials, but ours got up and going. So it was that sort of being able to look at the broad public health, as well as still working with people around a clinical perspective. And then from that, the area in the middle, that's not community health, that was specialist drug and alcohol services for people who are injecting drug users. So really taking on, again, a human rights framework to work with people. But it was also, from a nursing perspective, it was where I feel that I really got into advanced practice, working with people, testing, supporting them to get ready for treatment, being part of treatment, but also being part of a, I suppose, an innovative model of care as a nurse. And what was fantastic and still continues to this day is that we have graduate nurses coming into that program, and that's where they receive a lot of mentoring. And so as a nurse, as I've sort of walked through my career, being able to show some leadership in those nurses who now are highly skilled and sought after as groups of nurses. And then I think when the opportunity came, so I've worked in community health and our health centres merged, and there was recognition of a need for a practice leader in nurses, particularly around scope of practice, clinical governance, and professional developments. And there's about 15 different groups of nurses within the health service, and many of them are really clear around their scope of practice, but there are some that I want to do more work with around what we're talking about here today, developing models of care and really bringing, I suppose, the potential for nurses in the true, genuine sense of their role within a multidisciplinary team, and that recognition of what nurses bring, I think naturally, as part of it, becomes inherent, I think, in nursing practice, where that capacity to communicate with people, a bit like you were saying, that you can look at the client and the client can let you know what matters to them and what their healthcare outcomes. So I think that on the ground work is just really, really valuable, that first point of access often for people to engage in health. And so I think they've sort of been my drivers.
Great. And so what you mentioned you get your graduate nurses through. What do you tell them about their career?
About their career?
And what they should try to do.
Yeah, okay. So when I'm talking to them, I of course lobby for the area I was working in quite a lot, but it's about really getting an understanding of what's their passion as well, and about what the potential is. And I think, nursing over my period of time has just, there's so much growth in what we can do as nurses, and it's about that potential for them as people and satisfaction, but also professional development.
Fantastic. Thanks, Bernadette. So, Kathy, we've got yours here. I'm loving the blue as well. It's nice change of colour. So give us a sense of your career.
So I've spent most of my career in major public hospitals. So I started working, after I finished my university degree, I started working in orthopaedics, where I basically have stayed, until last September, for the past 18 years. I did the working holiday thing, so I did a year in a public hospital here, and then decided that I really needed to go to London, which I did and didn't particularly like it, and then decided to go to Scotland. I was going to be away for 6 months and ended up being away for 11 and a half years. So I spent much to my mother's disgust, as you can probably imagine. But I spent some time working in a public hospital over there as well. And then I did do some work in the community. I helped run and manage a home care company just outside of Edinburgh, and I did that for about 3 or 4 years. We came back to Australia in 2010, and I went, having done a little bit of work in community, not quite sure why, but went straight back into what I had always known. So I went back and worked in a major public hospital working in orthopaedics, because I guess that's just what I thought I was supposed to do and where I would end up. And then I guess I like being fallen into, because I think I definitely fell into working as a practice nurse. So last year, probably a classic story, the same as yours, children, husband, shift work, and decided that I couldn't juggle all the balls in the air anymore. And so horrendously, I spent one night Googling what else nurses do, because I just had stayed in the same area for such a long time that I really wasn't aware of what else there was to offer in our profession. And I found a job in practice nursing. I think I was particularly lucky. I was explaining to the other people on the panel, I think I was very lucky in that a lot of the jobs I applied for, they were looking for people with experience, and obviously I didn't have any experience. So I think I was particularly lucky to have found the place where I am working. And even luckier to now be part of the Transition to Practice pilot program. So.
Fantastic, thanks. And so you started your journey with Google as far as going into the primary healthcare bit. And we all know the kinds of questions we get from our patients when they come in having also consulted Google. And the great thing about Google is it throws back exactly what you ask it to. So it never gives you a few alternatives. So how did you get from there to where you are now? Like, what were the actual steps after getting that information? Because there's a broad amount of information there, and not all of it's great.
No, not all of it was great. And I think then I actually put into the Google search drive 9 to 5 nursing jobs. You can imagine, I have to say, I'd come home from work, I'd had a bad shift, I was in probably not a great place. My husband had gone to night shift and I had all these, kids to put to bed, and I was like, right. So I, frantically put this into Google, because Google has all the answers, obviously. And that, as you say, did spit out quite a lot of different things. And then I thought, what do I enjoy? What do I like? I knew that I always wanted to continue with the patient contact, which, although I'd worked in the community in Scotland, I sort of lost a lot of that. What my job was there was more managerial, so I was in the office and I had really missed the patient contact. So I sort of then went through and highlighted the things where I would still be able to have a lot of one-to-one contact. And then then took 9 to 5 out and put practice nursing in and looked at it through there. And then since then I've obviously started in a position where, thank goodness, I had other people that let me work alongside them for a wee while, and then have sort of really been absolutely astounded by what my role could be if I let it be, I guess.
Fantastic.
Yeah.
Thank you, Kathy. And for those who are here who may be in a policy role, perhaps in a certain department, I challenge you to come up with another profession that might, after 25 years' experience, get to the stage where to actually discover their next career step within their existing profession needs to Google it. And probably gives you a very, very instructive reason as to why this project's needed. So thank you for the funding, and we're going to do a really good job with this. Thank you very much, Kathy. That was fantastic. I think that was a very brave.
I promised I was going to be honest.
No,
so.
that's exactly what we wanted you to be, so thank you very much for that. Jo, give us a sense of your career.
I can't see my age there, so that's probably a bonus. On reflection, I think I just wanted to give you some sort of a sense of where I've come from, because I think it's really impacted on my career as a whole. So 1975 was an incredibly significant year for me because I lost my mum. I was 13. So she was a nurse and a midwife and an absolute inspiration. And I think that she's actually been my motivator for what I've done in my life and my career, I think, and I miss her terribly, but she's always with me. So in 1975, Liverpool Women's Health Centre was established. So there's a real connection there for me around now having worked in women's health for the last 20 years and at Liverpool Women's Health Centre for, it's now 5 years, I think. But I'll go into a bit more detail about that shortly. I grew up just out of Canberra and went nursing when I was 18. The course was called a 3-year supernumerary course. And it was a very innovative course. We were classed as supernumerary nurses. We weren't service-based. And we worked between Royal Canberra Hospital, which is now imploded, and Woden Valley, which is now the new Royal Canberra Hospital. So we moved around a lot with our, where we were. But I think that having done that and having the opportunity to also do further study, whether that be a tertiary course or courses, as an adjunct to that course that I did in nursing, instilled a passion for me for lifelong learning. And I guess you can see from the shaded areas, I have done a lot of study in my life. After I finished nursing, I worked, it seems to be common too with primary health nurses that we often work in acute care after we finished our training. So I worked in intensive care and I worked in neurosurgery, neuromedical ward. And then I went from the heads to the fannies, and I went to do midwifery. And someone actually said to me before I went to do my midwifery and moved down to the big smoke, which was Sydney, Jo's going off to become a boob and fanny mechanic. And I think that probably still it rings true today because that's what most of my work is. So I did midwifery, and I've been in Sydney then for probably the majority of my life, but I'm still very much a country girl at heart. I got a bit disillusioned with the hospital system as a midwife. I think that women at that time probably deserved better care than they were getting. I was quite interested in contraception, family planning, just pursuing that sort of area a little bit more, thinking a little bit outside the square, wanting to provide good information for clients. So I did the family planning course. And then the circumstances in my life were I became a sole parent, and I then needed the 9-to-5 job that you're all talking about. I worked in sexual health, I worked in a termination of pregnancy service, which was an amazing experience and really heightened my experience around domestic violence, sexual assault, child sexual assault. And then I got a job, I was also working for family planning, so I had a few jobs. I got a job at Leichhardt Women's Community Health Centre, which is the first women's health centre in Australia, established in 1974. And that got me really into women's health. I converted my hospital certificate to a bachelor degree. I did a graduate certificate in women's health nursing. I did a childbirth educators course and started doing 6-week groups and weekend workshops. And then I I set up some clinics, outreach clinical services, and then thought, I'm already being autonomous. Maybe I could pursue a nurse practitioner course, because at that time, that was around sort of the early days of the nurse practitioner movement, around 2001. So pursued further studies in nurse practitioner, and then because I work in non-government organisations, benchmarking is a real problem, and I think that could be flagged as an issue for primary health nurses, particularly when you're looking at salaries. Because what I had to do in order to become endorsed as a nurse practitioner was to be benchmarked to a clinical nurse consultant, and tiered to that classification. So to show, because I had a generic job description that just said I was working as a women's health nurse, which was clinical and education, and then that wasn't good enough according to the board. So they actually didn't endorse me the first time I had applied because of that. So I had to be benchmarked to that CNC role. It's very complicated, but it really took a lot of time to become endorsed because of the fact that I was working in primary health care, which I think is maybe a common thing with nurse practitioners in primary health.
That's a very interesting point. And I think I'll throw this one out to the panel. What are the skills that you've lost that you didn't like to lose in a transition? And did you lose them because the role had no need for that, or just because those skills weren't valued when you transition to another part of your career?
That's a very good question. I'd have to probably think a little bit more about that, but maybe other members of the panel?
I don't necessarily think I've lost any of my skills because I've taken a different approach, and I think myself and the other clinical members of the team of where I work, we really strive to embed our knowledge in general practice, so we're still keeping clinically up to date and trying to transfer that knowledge and our experience, but I probably do have to be, I'll be honest, like you, and I do miss the patient contact and that sense of achievement when you can actually transfer knowledge to them and help them change, so I do miss that.
I don't think I've lost the basic skills which I think are important to all nurses, and I think that's that non-judgmental approach, the empathy and the communication skills, and I think they're really important in primary health care as much as they are anywhere else. So I think that there are probably, I wouldn't know how to put together an iMed pump. I'd have to do a refresher course if I went back to work, but I certainly know how to, with the skills that I've got, the diagnostic skills, the skills to be able to ask and delve a little bit further into a patient history, and have developed further skills in some of the education that I've done as well. So push the scope of practice.
Great, thanks. Any other thoughts on that from the panel?
Yeah, in my experience, if I don't use it, I lose it. So there are a couple of clinical skills that I've definitely forgotten and lost. And I was just discussing the other night, someone mentioned a kangaroo pump, a little nasogastric feed pump, and I was like, what's that? It took me around 15 minutes to kind of remember what that looked like, and yes, I haven't used that in many, many years. So if that's personally for me, if I don't use it, I lose it. However, but I'm just so fortunate in my role that we get absolutely anything come through the door, so you might... the other week I put a catheter in. I haven't done that in a couple of years. That was just quite lucky. Had a PICC line a couple of months ago. That was like, wow, that's cool. So changing PICC line to police cells. So there are still, so I'm just fortunate that there are the odd little clinical skill that still comes up that I can still practice and do. But unfortunately, if I don't use it, I lose it.
Great, thanks.
I think when I came back from Scotland, I went and did a refresher program because I'd been out of the acute setting, so I presumed that I'd lost skills. And so I went and did a 4-week refresher program with the public hospital where I was employed, and I think I was incredibly surprised at the skills I hadn't lost. I think I was convinced that I would have lost skills, but in actual fact it was a 4-week program, and sort of by the second week they're going to me, you can just take patients, you're fine, on you go. Yeah.
Well, and that's great, and it leads into the next question quite nicely, which is what are the skills you've gained along the way that either have direct application that you didn't expect them to have, or that you've gained on a maybe not a nursing level, but just that's standing you in good stead for your career?
I think personally for me, it's my assessment skills have just shot right up there. So going probably still in the 2s, not up to the 3s yet, but definitely being in primary healthcare, that's been the sort of the biggest shift that I've seen in my skill base. In a hospital, you've got other people to rely on. You've got to, sort of not shortcuts, but you wouldn't do a full assessment, or you'd sort of miss bits because there's someone else to pop along and do the rest of it, or there's someone else to rely on, or there's someone else who's going to do the exact same questions that you're going to go as soon as you leave that cubicle. Someone else. So whereas out in the big wide world, it's all me. It's my decisions. It's my it's all led by the nurses. So that's my assessments are a lot more robust, a lot more thorough, and that's what I've seen as the biggest shift in sort of skills that I've gained.
Great, thanks.
I suppose I feel that I've learnt leadership and management skills, but also I think a really good understanding of the public health system and how that works. What are the potentials, for funding for, particular courses for nurse education, those sort of things are things I think have come along.
I guess I'm still obviously very much still learning, but I've only ever worked with adults. So obviously coming into the primary health and into a practice nurse setting, all of a sudden I'm faced with babies and children, and so that is very different to what I've been used to before.
Oh, and they're great after they've been in the waiting room for a couple of hours as well when doctors
really
running behind
too. Giving them an injection, they really love that.
I think for me it's client advocacy skills, and really because a lot of the community that I work with are incredibly disadvantaged, and even just working out letters of housing support, and just thinking outside the square, looking at the whole person, but also leadership as well, I think, and being a pioneer as a nurse practitioner in women's health.
Fantastic, thanks. So nurses, pretty fascinating bunch, right? And you're just like our panel here. So what I might get you to do is get that sheet that's in front of you on your table, which looks like one of the 5 that we've just shown you, and we're going to give you a bit of time to fill that out because we want to get a sense of your career pathway so that we can actually start having a sense of whether there are themes and running through the Australian nurses' environment when it comes to their career and education pathway. So we've got a few people from the team around, as well as other people from the office who can help you if you've got any questions on that. But what we'll do is we'll give you about 10 minutes to fill that out. Remember to look at the other side as well. The other side has a lot of contact details, and if you do want to be involved and have us continue to contact you to give you updates and to consult with you, then we'd like you to include those as well. What we'll do is we're running a little ahead of time, so we've got about 5 to 8 minutes for some questions if anyone has them. So what I might do is I'll invite Bronwyn back to the stage in case there's any questions about the project itself. And I might come down in the audience, and if you've got a question, just put up your hand. Excellent, that's working. Hello. Could you stand up and tell everyone who you are?
I'm Anne Mattia, and I'm a primary healthcare nurse, and I have been for quite some time. My question is, what is your definition of advanced and expert practice in the terms of this project?
Great question. I'll throw that to Bronwyn.
It is a really good question, and it's a question that I don't have an answer for yet. And the reason for that is we've just begun our 10-month consultation phase, and it was deliberate, putting advanced and expert up on these career maps up here, because we're wanting to test what that actually means to people and get a genuine sense of whether or not that as a terminology actually works. So we've taken that from looking at Canada and the UK and New Zealand, and it might be that we stick with it, but it actually might be that at the end of the 10 months we don't. We choose other terminology. So that's part of our consultation. We've got both face-to-face consultations and we have an electronic snowballing consultation, and that looks to seek consensus on some of these issues around terminology and on core skills and knowledge for primary healthcare nurses. So it doesn't answer your question, but it gives you an idea of where we're at.
Fantastic. Thanks, Bronwyn. Anne Johnson, welcome.
Hi, I'm Anne. I'm a member of the EPDAC committee. I have a question about consumer representation in the advanced clinics projects. Is there going to be any consultation with users of those clinics in terms of evaluation, in terms of the acceptability and appropriateness of the service that the nurses are providing, so that there's that perspective? Or is there going to be some kind of focus groups for users of the nurses' clinics?
I'll answer your first question first. We have an expert advisory group for the Nursing and Primary Healthcare program, and that will have 2 consumers on it from 2 different consumer bodies to represent the consumer voice. With the second part of your question about whether or not we're going to have, say, a consumer user-driven group, I think the answer to that probably comes at the very end of this project, depending on what sort of funding happens next, because it will take the whole of this project to generate models of nursing care. We're really at the very beginning where we're piloting models, and we'll come up with some characteristics and some ideas of what those models might look like. So I would think that if there's another round of NIPHC funding, that's when that element of the consumer-driven user group would come into it.
Thanks, Bronwyn. I'm going to pick on someone now because we actually have a few keynote speakers here, and it's great to have them here. So Kristen McClelland, who you all gave a standing ovation to yesterday, is here. Now, I had the luxury of sitting next to Kristen at the dinner before the conference, and Kristen said something very amazing, given everyone looked at her thinking, wow, she's going to war zones and all that. And she said, she turned to her partner, who was here, and said, actually, I've come to this conference, I've never had contact with this part of the profession before, and I feel that a whole world of nursing has just opened up to me, which I thought was a brilliant way of describing primary healthcare nursing. So, Kristen, I just wanted, and I know I'm putting you on your spot, whether you'd like to comment about what you've been seeing.
On the spot, absolutely. It's bad enough giving a presentation. I don't know. This is going to be very honest. I've actually come to a point in my career, having done all the spots and bits and pieces, I don't know, I should probably stand up, of what I've done, and I'm actually in the process of looking for a new passion and a new drive. Mission work isn't really sustainable when you think about moving on with life and having family and stuff, so I'm very much in that place of about to fall into something new, and I'm actually quite amazed how I was actually invited to come and to speak. I, to be entirely honest, had never heard of APNA before, having not really been in the country for the last 6 years. And coming here and seeing what I've seen and the incredible mix of people that are here from so many different backgrounds and the evidence from what we've just looked at the pathways that everybody's come, it's given me a great deal of hope that there is a direction out there, that everything that we learn and everything we bring to the table builds on who we are, and it does bring us to a point of finding something that is very useful for us all to be doing. So I guess I'm just inspired being here, seeing all the opportunities that are still before us. I don't know if that really answers your question.
Fantastic, thank you. Hi, Karen. Karen Cook is a great keynote speaker, and she keeps telling me she's invisible. We all know that at our conference she stands out quite a lot. So, Karen, what have you heard today that's piquing your interest in creating questions for you?
Oh my God. I'll stand up just to demonstrate that I'm not quite invisible. What have I heard today? In here or elsewhere? Oh, the career pathways. I'm loving the concept of falling into things. I've just done my map. Everything I've ever done I've fallen into. But I've put a thing on my map which is planned, which says retirement. In fact, it goes further. It says gleeful retiree and doting grandmother. And I've rated myself as an expert. I think the career planning thing is quite fascinating. I think it's very common in nursing to fall into things. I think it's very common to follow passions and then to look for passions. And I think when you find you're not passionate about one thing you're doing, you certainly start to look for it, even if you're doing it subconsciously. I'm interested by the concept of what Ben said. The medical people had their career planned from day one, and that is very common. And we know that because they graduate from medical school and that's where they stay. And they don't go anywhere. But nurses go everywhere, whether it's nursing or not. You scratch the surface of every health facility, of every health department, and there's nurses everywhere. It's like the Bachelor of Arts of Health. It just takes you everywhere, doesn't it? But none of us ever planned that. I don't see a problem with that. The only nurse I know who's planning her career is my daughter, and that's only because she's got a chronic medical condition, and so she won't be able to practice clinically for very long. But she's very clear that she'll stay in nursing. It'll just be about where in nursing she goes. But look how fabulous all of this is. All these people falling everywhere. What's wrong with that?
So do we just need porous walls for them to pass through?
I think we've already got those. We've heard that today. You know, how many years in orthopaedics before you just off you go into general practice and into women's health? And we've got the porous walls are there.
Fantastic, thank you. Any people game enough to follow Karen with a question? For our panel? There we go. We've got Will from the Medicross in Strathpine.
Yes. Hi, my name is Will, and I just have a quick question. I'm actually a recent graduate from the university, 2011, and then during the university life, I didn't actually get to know that much of the primary health at all, really. So do you actually have any future plans for the new graduates to implement some more of the programs, anything?
I couldn't quite hear you, but I think you were talking about new graduates. Is that right?
Yeah. Do you have any ideas for programs for new graduates?
Okay, great. Well, yes is the answer to that. We've got the second tranche of the Transition to Practice pilot program, and, well, let me go back a step. One of the really fascinating things about the first round of the expression of interest for this round of Transition to Practice was the overwhelming number that were new graduates, and that was actually the reverse of what we anticipated. So we thought that most would be established nurses looking to transition in, and we actually really had to pull together to find a balance between established nurses and new graduates. And still, even though the expressions of interest closed months ago, we've got phone call after phone call after phone call from new graduates. So there's some finite scope around what the second tranche will look like, but really there's only 25 positions in there, of which around about half would be allocated to new graduates. So I think that there's probably further scope to think about what that might look like and how we can talk about a broader program that encompasses just new graduates, because I think what we're finding is that the requirements and the needs of new grads are actually really different to that of transitioning nurses that are established. And last week we held our 2-day face-to-face workshop for the 25 nurses, and it was it was really apparent that the needs of the two groups are actually completely different, and combining them together in itself represents quite a challenge. We had people in the room like Kathy, who have got 18 years experience in the acute sector, and the whole breadth of knowledge of working with clients and patients is actually already established. And then we had nurses in the room who graduated in December last year and were Googling in between their patients coming in the room, just really lost. And I think that our understanding through this program is we're going to get a much deeper contextual understanding of the experience of new graduates in the primary healthcare setting, and that's probably the gap that's missing for us at the moment.
Fantastic, thanks. I think William's question opens up something really interesting, so I might jump it up a level. We've got Tiana here, who's from Asana. So Tiana, can you give us an idea of what this project means potentially for your members?
Firstly, I have a comment before my question. So I thought the career plan was really great. So like Karen was saying, I was actually a nursing student who started nursing, planning out my entire career. Coincidentally, I started out my career intending to do medicine, and I've now decided not to, but that's the mindset. And so seeing that up there and seeing how diversely your careers have changed has inspired me to be patient with my own career, because I'm like, I want to do this and I want to do this, and but I need time to do that. And so it's inspiring to see that there's such a diversity. I don't have to do everything right now. I've got 40 years of a career ahead of me, so that was lovely. Thank you. The question I have for you is, obviously there's a lot of graduate intentions. Do you see somewhere in the future, whether it's at the beginning or the end or somewhere in the project, for this to move into the university sector, for it to become whether an elective subject or a grad cert or anything in the student sector, because obviously students and novices are our speciality. So.
In the scope of this program, no is the short answer. But I think in the scope of a longer term program, absolutely. Because if we look back at the very beginning of one of those slides where we talk about recruitment of nurses into the primary healthcare sector, recruitment doesn't begin the day that you finish your university degree. Recruitment begins the day that you start your university degree, that is an undergrad. And we know that nurses that are exposed to primary healthcare are more likely to choose primary healthcare as a career choice. So I think it's just a matter of time before we move back further along that recruitment pathway and actually start at the very beginning.
Fantastic, thank you for that. So we're just on time and just at the end here. So what I'd encourage you to do is, if you haven't completed your tracker sheet, please do so. This is something that the team is trialling and something that will help us collect really strong information from you that will help inform this project, which, as we said at the very beginning, we're only a couple months into this, and this is a 3-year process which is going to lead inevitably to a number of very great outcomes, but also to a number of other things too. And I think some of the suggestions from the audience already are great ones and things that we need to sort of factor in as part of the development here. So thank you for your attendance. I'd particularly like to thank both the team leading this and also our panel for being so candid about their careers and potentially disclosing a bit more about their age than they probably do in public normally. Thank you for being so candid with us. They were fantastic stories, so a round of applause for them.